In the previous session, we have studied and analyzed the scientific aspects related to COVID-19, and today's session we shall look at what are the various diagnostic tools which are available for diagnosing COVID-19 as a disease. In terms of this diagnosis related to COVID-19 as a disease, there are three fundamental arguments one must remember which have been raised because of certain factors. What are these three arguments? These are three arguments, remember, are being raised in the wake of COVID-19 has been being declared as a pandemic. This must be kept in mind. So once it has been declared as a pandemic by WHO, which is true for almost more than 200 nations in the world, these three questions are really pertinent. The first question is, should every person be tested? Or, to put it differently, who must be tested? Secondly, are countries really testing enough? That means, are they really diagnosing all the cases which are there in the society? Thirdly, the important question that has been asked is, what is the appropriate diagnostic method or testing method or tool to confirm a particular case? So these are the three fundamental questions which have been asked, and these three fundamental questions arise because of one particular scenario that must be closely looked at. What is that scenario? Look at this particular picture. This picture gives you the scenario that I am trying to refer to. This is a particular curve which shows you the fact that what are the days and how the days are progressing and advancing, and the number of cases which are occurring daily. If you find that the healthcare system capacity is fixed, or you can also say that it is limited, then in the absence of the preventive or mitigating efforts in the form of protective measures by the citizens of a particular political entity called nation, then you find that the curve will bulge. That is, the number of cases will keep on increasing, and once you start implementing these mitigation efforts, it starts declining. And once these protective measures are being implemented by most of the members in the society or all of the members in the society, we find that the healthcare capacity will regain its ability to test and cure each and every case. Till then, you find that number of deaths and number of cases which have been tested positive on daily basis will be completely above this particular graph that we have, which clearly gives you the capacity of the healthcare system. This particular curve is important, and this has been termed as flattening of the curve. This is the reason why where the healthcare system has limited capacity for each and every nation given the economic capacity of that particular nation. These three fundamental questions have been raised. So this brings us to the next important discussion in the present session that we are going to have on COVID-19. There are at least four aspects which have to be understood in association with COVID-19 for its effective containment. What are those four aspects? Number one, you must track the virus. You must track the virus. Number two, you must also understand its epidemiology. You must understand its epidemiology. And thirdly, you must also have an informed case management. You must also have an informed case management. And fourthly, you must also have the possibility of suppressing transmission. As these four dimensions are fundamental in eradicating this pandemic, what holds key is the diagnosis. So everything falls down and back to what is called as diagnosis. So the diagnostic testing for COVID-19 is critical to all these requirements for its effective handling and control. The diagnostic testing for COVID-19 is hence having what is called as a strategic use given the different transmission scenarios of the COVID-19 outbreak. Because we have scenarios of no cases to community transmission depending upon each and every nation, this holds very fundamental. That is, the diagnostic testing holds very fundamental. Also, we do face, as I told you, the pathetic situation of prioritization of certain populations or individuals for testing, owing to the prioritization of certain populations having lack of capacity for getting tested, or prioritizing these population fundamentally because they lack the ability to test each and everyone because of the obvious reasons that we were citing earlier in the form of lack of healthcare capacity. Hence, it is also important for us to know how testing must also be rationalized. Testing must also be rationalized. So it is in this context those three fundamental questions are raised, and it is in this context we have to address all these four aspects that we are trying to understand in association with COVID-19 for its effective containment. Moreover, the decision to test must be based on both clinical and epidemiological factors and linked to an assessment of the likelihood of infection. Then the next question arises, what is this suspected case? How should we define it? Here WHO has given a fundamental definition of what is a suspected case, and this definition has been given for its purpose of surveillance, such that this pandemic can be contained. So countries may need to adapt a case definition depending upon their local epidemiological situation and also other such factors. So what is a suspected case? Suspected case will be the one where a patient with acute respiratory illness or fever and at least one sign or symptom of respiratory disease, for example having cough, shortness of breath, etc., and a history of travel to or residence in a location reporting community transmission of COVID-19 disease during the 14 days prior to the symptoms onset. I repeat, what is a suspected case? The first type of definition that has been given by WHO is that the patient with acute respiratory illness with fever and at least one sign or symptom of respiratory disease, for example of cough or of shortness of breath, and apart from this he also has a history of travel or residence, both travel or residence in a location which is reporting community transmission, of COVID-19 disease during the 14 days prior to the symptoms onset. Or you have one more form of definition, a patient with acute respiratory illness that we were referring to earlier, where he has fever and at least one sign or symptom of respiratory disease such as cough or shortness of breath, and he has been in contact with a confirmed or even the one which has probable COVID-19 case in the last 14 days prior to the onset of the symptom, I repeat, here the second form of definition is a patient with any acute respiratory illness. That means he has fever and also one of the symptoms of respiratory disease such as cough or shortness of breath. Along with this, he must have been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to the onset of this particular symptom. Thirdly, there is third definition. In this particular definition, we find that he is a patient with severe acute respiratory illness, that is fever and at least one sign or symptom of respiratory disease such as cough or shortness of breath, and he also requires he also requires what is called as hospitalization. Remember, for earlier two definitions, we had acute respiratory illness, where we were referring to fever and at least one symptom of respiratory disease such as cough and shortness of breathing. Now we are calling it severe acute respiratory illness. That means it's not just fever, it's not just symptom of respiratory disease such as cough or shortness of breath. It is also about the requirement of hospitalization. And in the absence of an alternative diagnosis that fully explains the clinical explanation, in the absence of an alternative diagnosis that fully explains the clinical explanation. These three definitions are what the WHO is using for what is called as a suspected case. Now, what is a probable case? Apart from the suspected case, we have another scenario which is called as a probable case. A probable case has been defined by WHO in two ways. Number one, it says that a suspect case for whom testing for the COVID-19 virus is inconclusive. Secondly, it says that a suspect case for whom testing could not be performed for any reason. So these two particular types of cases are called as probable cases. Thirdly, you have what is called as a confirmed case. What is a confirmed case? Confirmed case is the one where a person with laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms, has been concluded. So here he has been confirmed with the case of COVID-19. Apart from this, you also have what is called as definition of contact. A contact is a person who experienced any of these exposures during the 2 days before and the 14 days after the onset of symptoms of a probable or confirmed case. What are those exposures that he has felt or experienced during these days of 14 days? One is face-to-face contact. The second one is the direct physical contact. This direct physical contact will be either with probable case or with the confirmed case. Similarly, when he has this face-to-face contact, he will be having it with a probable case or confirmed case within 1 meter and for more than 15 minutes. Thirdly, we find that the contact is also about the direct care for a particular patient with probable or confirmed COVID-19 disease without using appropriate or proper personal protective equipment. Or the fourth scenario which gives you the aspect of contact is those other situations that might be indicated by various local risk assessments. So this particular confirmed asymptomatic cases or the period of contact which is measured as 2 days before through the 14 days after the date on which the sample was taken, which led to confirmation, is what very significant for considering what is called as a contact case. Apart from this, ICMR has given us some of the guidelines as to whom to be suspected and when to be suspected. All the symptomatic individuals who have undertaken an international travel in the last 14 days, of his stay in India must be considered to be suspected. Secondly, all symptomatic contacts of laboratory confirmed cases must be suspected. Thirdly, all symptomatic healthcare personnel must be suspected. Fourthly, all hospitalized patients with severe acute respiratory illness, that is fever and cough or shortness of breath, must be suspected. Fifthly, all the asymptomatic direct and high risk contacts of a confirmed case must be suspected. Here, as I told you, this particular definition has been altered as per the local requirement. Even though WHO has recommended to be 2 days and after the 14 days, here the ICMR recommendation is that one must be tested once between day 5 and day 14 after the contact. Along with this, you must remember that symptomatic refers to either fever or cough or shortness of breath. This as per the ICMR guidelines, and accordingly the direct and high risk contacts as per the ICMR's guidelines include those who live in the same household with a confirmed case and healthcare personnel who examined a particular confirmed case. What is a confirmed case as per the ICMR guidelines? A person with laboratory confirmation of COVID-19 infection irrespective of clinical signs and symptoms. Remember, recently the CDC of USA has added some of the symptoms as possible indicators of COVID-19, the infection that has been caused by the coronavirus. They include the chills. Secondly, it include repeated shaking. Again with chills. Thirdly, it includes muscle pain. Fourthly, headache. Fifthly, sore throat. And the sixth one, new loss of taste or smell. All these have been added as new symptoms for COVID-19. Along with this, we must also remember that there is a methodology of transmission that has been defined or classified by WHO. WHO recommends using these particular categories to describe transmission patterns at national and subnational levels, such that this can guide decisions not only for preparedness but also for readiness and response activities. Remember that it is this classification which has to be ensured in such a way that this is the diagnosis of the disease which leads to the absolute and appropriate classification that has been defined by WHO. In this particular classification, the transmission pattern will be understood. First category that is being defined by WHO is the category of no cases. The second category is the sporadic cases. The third category is clusters of cases, and the fourth category is the community transmission. What is this no cases as a category has been defined? The no cases as a category has been defined with respect to countries or territories or areas where no single case has been registered. Secondly, what is the sporadic cases? The countries or territories or areas with one or more cases, either imported or locally detected. Thirdly, you have these clusters of cases where the countries, territories or areas experiencing cases which have been clustered in time or which have been clustered geographic location basis, and they have had the common exposures. So these clusters have been defined. Now, fourthly, you have what is called as community transmission, where countries or area or territories are experiencing larger outbreaks of local transmission defined through an assessment of factors including, however, not limited to the large number of cases not linkable to the transmission chains, large number of cases from sentinel lab surveillance, and multiple unrelated clusters in several areas of the country, territory or area. All these classifications, whatever that we have, require diagnosis as a fundamental tool to know whether this phenomena is occurring in a particular area or not. So any persons meeting the criteria for testing should be tested for COVID-19 infection using the available molecular tests. However, depending on the intensity of the transmission, depending upon the number of cases and also the laboratory capacity, as I told you, only a subset of the suspected cases may be prioritized for testing, just because we had to compromise or prioritize depending upon the healthcare system's capacity. Out of all these diagnostic tests, we have one test which is referred to as RT-PCR. This RT-PCR is the one which has been used worldwide for diagnosing the COVID-19 disease. RT-PCR, remember, is a nucleic acid amplification test. Nucleic acid amplification test. In the last session we have understood the structure of the coronavirus and we found that it is the single strand of RNA which is the fundamental part of this particular virus. So the suspected cases should be screened for the virus with this nucleic acid, and the test that we use is amplification test. This particular amplification test is what being referred to as RT-PCR. So the rapid collection and testing of appropriate specimens from the patients meeting the suspected case definition for COVID-19 holds fundamental. Rapid and testing of appropriate specimens. This is fundamental in what? This is fundamental in clinical management and also outbreak control, whereby the laboratory expert must ensure the rapidity of the collection of the sample. Why this is being held as key? This has been held as key because the test itself gives a kind of discomfort to the patient as you collect the sample from some of the sensitive parts of your body, which is the nasopharynx. Thirdly, we find that there is a particular pattern that the virus observes, which is called as virus shedding patterns. So these virus shedding patterns hold the key for better understanding of the timing, better understanding of the timing of the sample collection. Secondly, better understanding of what is called as compartmentalization. Thirdly, even the quality of viral shedding to inform optimal specimen collection. All these three give us the need for collecting optimal specimen collection, or they are the parameters which have to be considered as to how much sample will be considered as optimal specimen. So although the respiratory samples have the greatest yield, the virus can be detected even in the other specimens as we have observed, including the stool and even the blood. So also it is very important to adhere to some of the local guidelines which have been issued, and these local guidelines are pertinently related to what is called as consent, because this aspect is related to the matter of privacy as per the law. Hence, consent should be followed for specimen collection, for specimen testing, and potentially for future research also. At minimum, this respiratory material should be collected, remember, from the upper respiratory specimens, which is called as nasopharyngeal and oropharyngeal. And this particular specimen is collected within days of the occurrence of the COVID-19 symptoms. Remember, this sample contains a small quantity of the viral RNA, very small quantity of viral RNA. Or whenever this particular disease has been diagnosed after a few days, such as after 1 week or 10 days, then these particular samples may not hold good for the diagnosis, and hence you must go for the lower respiratory specimens. So once you collect these lower respiratory specimens, such as from the endotracheal region or bronchoalveolar region, they might give you the possible positive results with patients where you find more severe respiratory disease. Here you must also remember that it is highly risky for the healthcare worker who is collecting these samples. So these are called as swab tests, and swab is the piece of material that is used in medicine for taking what? The specimens. CDC, for example, recommends to use only synthetic fiber swab with either plastic or wire shafts. However, I heard that we use either calcium alginate swabs or swabs with wooden shafts having a cotton on its surface to collect the sample, and because of this the patient feels a lot of discomfort, and it's also difficult for the healthcare worker to collect the sample at an optimum time within a limited time period, and because of this many of the specimens seems to be failing to give the effective results, and hence we find that there are certain cases where even though he has been infected with the virus, the results in the diagnosis are showing the negativity. Because of this, we find that having a significant part of time with respect to the training of these healthcare functionaries holds lot of importance in ascertaining this particular disease. Now CDC is also recommending collecting only the not only the nasopharyngeal swab, but also even the swab from the lower respiratory specimens, as I told you. Additional clinical specimens, as I told you, can be available even through the stool or also from the blood. So additional clinical specimens may also be collected as COVID-19 virus has been detected in blood and stool, as had the coronaviruses responsible for SARS and MERS that have been understood in the past. So the duration of frequency of shedding of COVID-19 virus in stool and potentially in urine is still unknown, yet these samples are being collected for understanding the COVID-19 disease in terms of diagnosis. In case of patients who are diseased or have died, considerable autopsy material including the lung tissue is being collected. So in surviving patients, we also collect not only these particular lower respiratory specimens or the upper respiratory symptoms, even the paired serum, which is called as acute and convalescent serum, will be collected, which is useful to retrospectively define cases as serological assays become available. What is this serological assays are being discussed or will be discussed a bit later. So testing for COVID-19 virus must be done adhering strictly to certain appropriate biosafety practices that have been referred to by not only WHO but also even the ICMR, given the local conditions that we have. So routine confirmation of cases of COVID-19 is based on detection of unique sequences of virus RNA by what? NAAT, as I was referring to earlier, such as the one which is called as real-time reverse transcription polymerase chain reaction, where we try to confirm the nucleic acid sequencing when it is necessary. So the virus RNA is amply multiplied under the laboratory conditions, because whatever the sample that we collect will have a very minute quantity of viral RNA, and this will be multiplied over a significant period of time, because of which the amount of RNA will be multiplied to a larger extent. One or more negative results may be possible, as I told you, because of the inefficiency or lack of training for the healthcare professional who is collecting the sample. However, they do not rule out the possibility of COVID-19 virus infection. So a number of factors could lead to a negative result apart from that. As I told you, the poor quality of specimen containing little patient material can be one factor. Secondly, the specimen was collected either late or very early. Either late or very early in the infection. Thirdly, the technical reasons inherent in the test, such as the viral mutation, might also be a possibility which has been detected by the CCMB and over which there is research going on this viral mutation, or even the PCR inhibition that it might have developed going against the test results which might yield the positive results. Hence, adequate training of the technicians, as I told you, is a very important step in having effective fight against COVID-19. If a negative result is obtained from a patient with a high index of suspicion for COVID-19 virus infection, particularly when only upper respiratory tract specimens were collected, additional specimens including from the lower respiratory tract if possible must also be collected and tested, as I told you. So many aspects of the virus and disease are still not understood. Hence, this holds very fundamental in diagnosing the COVID-19 disease. So a better understanding will be needed to provide improved guidance. For example, you had many viral dynamics that must be understood. What is that optimal timing at which we must collect the sample? What is the type of clinical material which is suitable for such molecular testing? And what is the dynamic of this immunological response from the patient? What is the disease severity in various populations in terms of either age or either demography or various other factors? What is the relationship between viral concentration and the disease severity? What is the duration of shedding of the virus, and what is its relation to the clinical picture which is being shown? And apart from that, the development and validation of useful serological methods to deal with this particular diagnosis. What are the comparative studies which are available in terms of the molecular diagnosis of various population that a particular nation has, and what are the various data that is available with respect to this serological method? So there are many aspects that must be understood with respect to the COVID-19, and only then we can clearly address the pandemic as a situation that we are facing today. However, although the virus nucleic acid real-time polymerase chain reaction test has become the standard method for diagnosis of SARS-CoV-2 infection, we find that these real-time PCR test kits have certain limitations. We clearly know that there are some high false negative rates which were reported. High false negative rates which were reported. Here, this is one particular limitation that we have with respect to the PCR tests. Apart from that, these tests have, as I told you, long turnaround times and are complicated in operation also because of certain limitations that I was referring to in terms of training of the healthcare personnel. So they generally take on an average a long time to generate results. Secondly, we find that the PCR test require what is called as certified laboratories, which is a practical problem. Certified laboratories. In the wake of this has been seen as a pandemic, on an urgent basis, certain private laboratories have been given the permission to diagnose the COVID-19 patients for a certain fee. This is a practical problem that we have. Thirdly, we have the problem of expensive equipment. We also have the problem of trained technicians, the lack of trained technicians. So there are a number of negative aspects that are also associated with the RT-PCR of COVID-19. Moreover, we find that the clinical signs and symptoms of viral RTIs overlap with those of bacterial infections. When this overlap is being found, it is really challenging clinically. It is really challenging clinically to distinguish bacterial form of infection from the viral form of infection and different viral pathogens. And this diagnostic uncertainty, whatever that we have, leads to oversubscription of antibiotics and extra diagnostic testing to rule out the possibility of bacterial infections. So there are a number of such problems even that RT-PCR has. Because of this, rapid detection of viral pathogens could overcome these disadvantage, and this idea of rapid detection of viral pathogens has its basis from these limitations that we find with the RT-PCR. So these limitations of RT-PCR make it unsuitable for use except in the field where there is enough time available for us, keeping in view the healthcare infrastructure and its capacities or capabilities. it remains unsuitable for use in the field where we are finding it rapidly transmitting and the pandemic situation is clearly visible, which calls for the rapid and simple diagnosis and screening of patients. So it limits the outbreak containment effort. Therefore, there is an urgent need that was felt need for a rapid, simple to use, sensitive and accurate test to quickly identify infected patients of SARS-CoV-2 to prevent virus transmission and to assure timely treatment of patients. So in response to this growing COVID-19 pandemic and whatever the shortages that we have of this laboratory based molecular testing capacity, we find that the manufacturers have developed and began selling what is called as rapid and easy to use devices to facilitate testing outside the laboratory settings. So these simple to test kits are based either on detection of proteins from the COVID-19 virus in this respiratory samples such as sputum or throat swab, or detection or in blood or serum of human antibodies that have been generated in the response to the infection. That means we have two other methods apart from RT-PCR to detect or to diagnose the COVID-19 disease. One must applaud the efforts of these test developers to innovate and respond to these needs of the population. However, before these tests can be recommended, they must be validated in the appropriate populations and settings as WHO and in the Indian conditions ICMR has called for. So inadequate tests may miss patients with active infection or falsely categorize patients having the disease when they do not actually, further hampering the disease control efforts. So at present, based on the current evidence whatever we have, WHO recommends the use of these new point of care immunodiagnostic tests only in research settings, and it says that they should not be used in any other particular setting including for clinical decision making except by the RT-PCR until evidence supporting the use for specific indications is available. So we have two kinds of tests as I told you. The rapid diagnostic tests based on antigen detection and the rapid diagnostic tests which are based on the host antibody detection. So viral protein antigens in the first type of rapid diagnostic test and antibodies that are created in response to a SARS-CoV-2 infection can be used for diagnosing COVID-19 in a rapid manner. So changes in the viral load over the course of the infection, remember, may make viral proteins difficult to detect. For example, lung has showed high salivary viral loads in the first week after the onset of the symptoms, which gradually declined with time. So in contrast, antibodies generated in response to viral proteins may provide a larger window of time for indirectly detecting SARS-CoV-2. So antibody tests can be particularly useful for surveillance of COVID-19. One particular potential challenge with developing accurate serological tests includes potential cross-reactivity of SARS-CoV-2 antibodies with antibodies which are generated against other coronaviruses. This has been a challenge that has remained. So there were many plasma samples that were tested against the plasma samples of other coronaviruses, and it has been found that there was a high frequency of cross reactivity. So currently the serological tests, what are the serological tests? The blood tests. Serological tests are the blood tests which are done for specific antibodies. These particular serological tests are still in the stage of development. We find that one type of rapid diagnostic test that detects the presence of viral proteins expressed by the COVID-19 virus in a particular sample from the respiratory tract of a person is the antigen based test. So these viral proteins are in the form of antigens. If the target antigen is present in sufficient concentrations in the sample, it will bind to specific antibodies fixed to a paper strip enclosed in a plastic casing and generate a visually detectable signal typically within 30 minutes, as it has been found in the research. So the antigens which are detected are expressed only when the virus is actively replicating. Virus is actively replicating. Therefore, such tests are best used to identify acute or early infection. However, we identify at least two limitations with respect to this rapid test kit which identifies the presence of antigens. They are: number one, half or more of COVID-19 infected patients have missed by such tests. They have been missed by such tests depending upon the group of the patients tested. So this is a fundamental problem. For unknown reasons, we have faced this issue. Secondly, we find that there are false positive results. These false positive results probably are occurring because of the fact that these false positive results, this occurs probably because of the reason that the test strip that we use to recognize the antigen related to COVID-19 disease is also recognizing the antigens of various other viruses other than COVID-19, such as from human coronaviruses that might cause the common cold. So because of these two problems and also because of the limited data which is now available, WHO does not recommend the use of antigen detecting rapid diagnostic tests for patient care, although research into their performance and potential diagnostic utility is highly encouraged by WHO. Secondly, we have another rapid test. This is related to the more common type of rapid diagnostic test which is being marketed for COVID-19, which is a test that detects the presence of antibodies in the blood of the people believed to have been infected with COVID-19. So antibodies, as you know, are produced over days or weeks after the infection with the virus. These are called as immunoglobulins. These immunoglobulins, which are also referred to as antibodies, are fundamentally the glycoprotein molecules, as they are called, produced by what is called as plasma cells, which are part of the white blood cells, as we have understood in the earlier session. So they act as a critical part of the immune response by specifically recognizing and binding to particular antigens such as bacteria or viruses and aiding them in their destruction. So testing for specific antibodies of SARS-CoV-2 in patient blood is a good choice for rapid, simple, highly sensitive diagnosis of COVID-19, as it has been understood. So it is widely accepted that immunoglobulin M, which provides the first line of defense during viral infections because it is part of IgM, immunoglobulin M, is part of what is called as innate immune system that we understood in the earlier session. However, before the generation of adaptive and highly affinity oriented response called IgG, which is immunoglobulin G response, which is part of adaptive immune system, which are important for long-term immunity and also immunological memory that has been carried forward by the immune system, where it can obstruct any further return of this particular COVID-19 disease into the same individual. So it was reported that after SARS infection, this IgM antibody could be detected in patient blood after 3 to 6 days, and also IgG could be detected after 8 days. Since COVID-19 belongs to the same large family of viruses as those that cause the MERS and SARS outbreak, here it has been assumed that its antibody generation process might be similar, and the detection of these two, IgG and IgM antibody against SARS-CoV-2, will be an indication of an infection. Furthermore, the detection of IgM antibodies tends to indicate recent exposure, to the SARS-CoV-2, whereas the detection of IgG antibodies of COVID-19 indicates that virus exposure has occurred some time ago. That means the detection of both IgM and IgG could provide information on the virus infection time course, which is also very important data which will be made available because of this rapid test based on antibodies. So the rapid detection of both IgM and IgG antibodies will add value to not only the diagnosis of the COVID-19 disease but also to treatment of COVID-19 disease, because on the basis of the time which has been lapsed, the treatment plan can also be ascertained. So the strength of antibody response depends, however, upon several factors. There are many factors which influence this response system or immune system. Number one, age. Number two, nutritional status. Number three, severity of the disease, and certain other medications or infections like HIV which he might be going through, which might have suppressed the immune system. So these are the factors which impact the antibody response. So in some people with COVID-19 disease confirmed by molecular testing, we find that weak, late or absent antibody responses have been reported. Studies have also suggested that the majority of patients develop antibody response only in the second week after onset of these symptoms of COVID-19 disease. This means that a diagnosis of COVID-19 infection based on antibody response will often only be possible in the recovery phase if we apply the RT-PCR test, when many of the opportunities for clinical intervention or interruption of disease transmission probably might have already passed. So antibody detection tests targeting COVID-19 may also cross-react with other pathogens, including other human coronaviruses, which is also one more negative aspect that we have with this. And along with this, they have also reported the false positive results. This is also one of the fact that we must remember. And recently we have Indian ICMR has banned the Chinese rapid test kits because of these false positive results which have been seen. So lastly, there has been discussion about whether these tests detecting antibodies could predict whether an individual was immune to reinfection with the COVID-19 virus or not. There is no evidence till date to support this particular aspect. So there are a number of limitations even with respect to the rapid test related to the antibodies. So tests to detect antibody responses to COVID-19 in the population will be critical to support the development of vaccines. We know that. And to add to our understanding of the extent of infection amongst people who are not identified through active case finding and surveillance efforts, the attack rate in the population and also the infection rate, this holds very, very important. So for clinical diagnosis, however, such tests, as I told you, have limited utility because they cannot quickly diagnose the acute infection to inform actions needed to determine the course of treatment, as we can find antibodies only at a later stage of the disease or during the recovery stage of the disease. So some clinicians have used these tests for antibody responses to make a presumptive diagnosis of recent COVID-19 disease in cases where molecular testing was negative, but where there was a strong epidemiological link to COVID-19 infection and paired blood samples showing the rising antibody levels, we have seen both the tests being used. So based on the current data, again, WHO does not recommend the use of antibody testing rapid diagnostic tests for patient care, but encourages the continuation of this work to establish their usefulness in the disease surveillance and also epidemiologic research. Here you must also remember that recently Delhi Chief Minister has, and prior to that Kerala Chief Minister have come out saying that they have applied what is called as plasma therapy. This plasma therapy is clearly based upon this immunoglobulin response that we find in the body owing to the attack of this viral infection. They are hence used in this plasma therapy. However, we shall look at these particular plasma therapy and various other treatment practices which are available in the next session. Yesterday, we also find that a new test for coronavirus, which is simple and straightforward, where almost everyone can do or anyone can do it at their home has been developed in USA, where you can spit a glob of saliva into a cup and then you can close the lid and you can find whether you have been infected or not, which is again a saliva based swab test which has been found for the diagnosis of COVID-19. However, again these have the same kind of limitations that we have pointed out, and hence still we find that WHO has not recommended these as the productive tools for diagnosing COVID-19. So the main issue that we have here also is, as part of this limited capacity of the healthcare infrastructure, the main significant limitation that we find is the adequacy of personal protection equipments. Such tests will have the strength and ability to reduce the dependence on this requirement of PPEs for healthcare functionaries. Hence, these tests must be encouraged for further advancement. So, the emergence of a new virus means that understanding the transmission patterns, understanding the severity, understanding their clinical features, and also understanding the risk factors which are associated with the infection. So these will be limited in terms of knowledge at the start of an outbreak, and even today when it has been declared as a pandemic, there is much of a limitation with which we are faced with. So to address these unknowns, we must remember that diagnosis holds key, and along with this, in order to address these unknowns, WHO has called for having 4 investigation protocols. These investigation protocols are designed to rapidly and systematically collect data and also share this data in a particular format that can facilitate what is called as aggregation, such that this entire data is globally available to understand and compare the various facets of COVID-19 disease, such that this pandemic can be contained. Data which has been collected using these investigation protocols will be again critical to redefine and refine the recommendations which have been made for case definitions for their surveillance, which is fundamental in the times of pandemic, then also characterize the key epidemiological features of COVID-19 and to understand its spread, severity, and also the spectrum of the disease and its impact on the entire community, such that the guidance for application of countermeasures such as case isolation or contact tracing can also be developed, and all these fundamentally require diagnosis as mechanism, and hence RT-PCR, which has been declared as the standard diagnostic method, holds key for these entire steps that can be initiated. And remember, in medical terminology, we use this expression called gold standard test, and RT-PCR can be termed as gold standard test for COVID-19 patients in the present scenario. What is a gold standard test? A gold standard test is a best available diagnostic test for determining whether a patient does or does not have a particular disease or condition. This is what all the information related to the diagnosis of COVID-19 is all about. In the next session, we shall look at what are the various treatment or therapies which are available for treating the COVID-19 disease.